Good morning, everybody. It's our pleasure to be with you this morning to discuss a little bit about neuroimaging and the time of Alzheimer's disease therapy. I'm Val Lowe from Mayo Clinic, and my co-chair is Lowe Raji from WashU. This meeting is being presented by PeerView and Lily, and we'd like to thank them and Lily for providing the support for this meeting. You've got a pre-survey to fill out. Please do that during the talk. So you're going to have some polling questions pop up. We're going to move pretty quickly through those, so don't perseverate too much. Just punch something. You're not going to be stopped at the door on the way out if you answered wrong. Just take a guess. And these slides will also be available in the future for review. So everything that's here is going to be available for you to look at. And some links here to keep in mind to do that. So I'm going to start off and talk a little bit about background, and then I'm going to be talking about PET imaging and some fluid biomarkers that you need to be familiar with in this field. And then Cirrus is going to follow up with the MRI components in ARIA. Today we have an opportunity to treat one of the pathologic hallmarks of Alzheimer's disease, being amyloid. And we need to be able to identify that pathology prior to doing therapy. In October 23, CMS lifted a national no coverage policy on reimbursement for amyloid PET. And now that coverage is determined by your local Medicare contractors. The black box warning was issued for this drug, which required MRI to assess for amyloid-related imaging abnormalities, or ARIA, and Cyrus will go over that in detail later. So that's why we have opportunity for these two modalities to play an important role in therapy for Alzheimer's disease. So our goals are to really help you to be able to perform neuroimaging for Alzheimer's disease and understand fluid biomarkers in terms of what's needed to determine eligibility for amyloid targeting therapy. We want to help you to be able to detect what's abnormal, and we want to give you maybe some tips on how to report this and communicate this with the team at your institution. So I'm going to start out talking a little bit about fluid biomarkers. There's been a number of years that have passed where we've described the cascade of pathology occurring in the brain using neuroimaging and how it happens many years before people have clinical Alzheimer's disease dementia. And that's been categorized in some tables, which you may have seen. We're not going to go into a lot of detail about that, but things that tend to help us characterize amyloid pathology, tau pathology, or neurodegeneration. Various ways we can do that. Fluid biomarkers with CSF and blood, but also with imaging, PET, MRI, and some other things. So there's a lot to kind of put together when you're talking about these people and how to characterize Alzheimer's disease pathology. I think the important thing to remember is that the whole categorization has changed from a clinical syndrome, at least it's moving this way, to a pathologic syndrome, where we find that the pathologic disease, sometimes the people don't have the dementia, but we want to characterize disease as a pathological entity that it is. So fluid biomarkers look for separate things for different applications. We have phospho-tau that we look at. We have total tau, A-beta, as long as ratios of those things, A-beta 42 or A-beta 40 as one of the ratios. And there's advantages and limitations to each of these modalities, and using all of them may be something we do, maybe something we don't do. But PET scans have been around for a long time. We understand them in imaging very well. There's multiple FDA-approved tracers. However, they are costly. There's some radiation involved, which scares some people. There's limited capacity. CSF is also approved by the FDA. It's paid for by Medicare. It is somewhat invasive. There are some contraindications. Plasma markers are maybe the hope for the future. It's easiest to do, maybe the least costly, less invasive. However, at the moment, there's a fair amount of variability with the assays, and it's not reimbursed by CMS, so it's a work in progress, but looks promising. Just one slide about why choose one or the other. In CSF, p-tau over A-beta 42 ratio has been shown to be one of the best performers as it compares to amyloid PET. and some scatter plots here showing a t-tau and p-tau on the right, showing better rho values than what we see with just single A-beta-42 or A-beta-42 ratios. And I'll just show you this one pull-out of this figure from a paper that was published recently showing the AUC of p-tau ratio over A-beta-42 is pretty good. So plasma tests, I'm just going to mention that as something promising. You know, hopefully one of these will turn out to be a success. In the revised criteria of staging, diagnosis and staging of Alzheimer's disease, the request is to have a test that's 90% accurate. And I think we're having some challenges in getting the plasma test to that range, but we're hoping that will happen. The potential for a fluid biomarker is to really categorize people maybe into probability groups, low probability, maybe just get away with nothing. If they're intermediate or higher, maybe that needs to be confirmed by another test to be sure. So let's talk about amyloid PET a little bit. Amyloid PET is, like I said, it's an imaging modality that has a number of radio tracers that are approved. They function pretty much the same in terms of performance and in terms of how you interpret them. The companies have published interpretation guidelines that you can go and do training modules to up your game here in terms of what you know about interpreting amyloid PET. Typically, on reporting these, I think we want to be pretty cautious because a positive amyloid scan doesn't mean you're going to have Alzheimer's disease dementia or even have dementia from an Alzheimer's pathology. So we need to report these as being positive for amyloid or negative for amyloid and kind of stop there. Typically, the negative is going to mean there's not much for amyloid pathology, and positive means there is. Now, how do we read a PET scan? These are groups of people, left to right, not impaired, MCI-AD, and you're going to see a variety of PET scans in the first two groups. Hopefully not as much variety in the last, but sadly you do sometimes. What do we look for in a positive PET scan? Well, we really look for white matter contrast. There's a non-specific off-target binding in the white matter, irrelevant to the diagnosis of Alzheimer's disease. The gray matter ribbon is where the amyloid of concern is going to accumulate, and when that does, it's going to basically make the uptake look homogeneous, like we see on the high levels in the bottom. So that's what your target is. Amyloid imaging interpretations, once you've seen a bunch of them, gets relatively simple. You have to watch out for some of the artifacts. But that's what you're after, a pattern that shows this finger-like, white matter uptake throughout the brain versus homogeneous uptake right out to the gray matter ribbon. So let's look at a few cases. My goal here is to show you some things that might help you in some of the common challenges and show you some examples. Now, the cases I'm showing you here in this slide, all pathologically proven. So these cases are what you're going to see in people who show up with amyloid. This first one, positive, right? It's homogeneous uptake throughout the signal right out to the gray matter ribbon. This one's negative, right? You see the gray matter pattern. Sorry, the white matter pattern. This is another negative, a little bit different, slice. What's this case? This is this homogeneous uptake out to the gray matter ribbon. This is also positive amyloid scan. Now, is this different than the one on the left? It's a little different intensity, right? So there's two kinds of amyloid in the brain. There's amyloid that's attached to the neurons, neuritic plaque. There's also amyloid that's diffuse, floating out there in the interstitial space, maybe not pathologic. That's a type of amyloid that may not be associated with pathology of Alzheimer's disease. It's more sometimes common to see it with Lewy body dementia. So that's something to keep in mind in terms of intensity of the uptake that you're seeing in that PET scan. Okay, how about this case? You're right, positive amyloid scan, but not entirely homogeneous, but only regionally. How about this case? You don't see the great separation between white matter and gray matter, right? Positive. What's this? Regional positivity, where you don't see it everywhere. But this is also called positive by most of the interpretation things you'll see, and it's also indicating amyloid. As shown, these are all pathologically proven amyloid positive cases. What about this? Not so much in the back, in the occipital lobe, posterior temporal lobes, but frontally this person's got some amyloid. How about this? Kind of blurring all over on this case, and this is also a positive case. All right, so interpretation of amyloid scans, you know, amyloid can be present for a long time before people have Alzheimer's dementia, so it doesn't mean Alzheimer's disease dementia, or even that they'll get it, but it's a positive amyloid case. So it means that it's more likely to be Alzheimer's disease, but you just want to read whether it's a positive or a negative amyloid scan indicating the presence of amyloid. You can use quantitation to help you. You'll see lots of papers published using things like SUVR, that's the standardized uptake value ratio, which is a ratio between the cortical signal and some reference area, typically cerebellum, or maybe sometimes even white matter, to see how much different it is from things that are, you know, supposedly normal. We also use a term called centiloids, which is a way of trying to normalize the data seen in different institutions and get everybody on the same page, because the SUVRs, depending upon how you use your normalization, can vary by a lot. So centiloids is a way of trying to peg what you're doing at your institution to a standard scan, and typically this done, standard is PIB PET, and so it allows you to sort of compare between places and between different places that might do therapy. And this is what we do, is we take the SUVR, put it on the x-axis, and try to normalize that to a 1 to 100 scale, centiloid. And typically the cut point here is about 25 to 26 between abnormal and normal. Above that, positive; below that, negative. The early cases I've shown you, a little bit here, a little bit there, are typically going to be in the range of 15, a little bit lower than 25. So you're going to see those things visually, they'll be positive, but they may be centiloid negative, and vice versa. The same thing can happen visually. So I've got some polling questions for you. We're going to do a quick kind of run through some cases, and you'll have your iPad to answer these. The amyloid PET scan shown here is negative, positive, or you're not sure? It's negative, right? So we're seeing the good contrast between white matter and gray matter. This has a high SUVR of 1.57, so it's a false positive quantitatively. So don't put everything in the bucket of quantitation. Why are these sometimes positive? White matter signal is often, and a PET scan is diffusing into the ROIs that are measured by the quantitative program, and it elevates the signal falsely if the white matter is high. Why is the white matter sometimes high? It becomes higher in age, becomes higher with some diseases. It is a little variable, nothing to do with Alzheimer's disease. So that you have to keep in mind, and still consider the two together, the visual read. This patient had Graves' disease, the thal was 0, there was no diffuse plaque in this patient. Again, it's an autopsy case. So consider high white matter as one of the artifacts that you might want to think about when you're doing quantitation. What about this scan, amyloid PET? Negative, positive, you're not sure. I've added some arrow signs, not that on this case you really need it, but. Right, it's a positive scan. What was this? High SUVR, so quantitatively positive, visually positive. Path diagnosis, this is transitional Lewy body disease in a patient with a floridly positive amyloid scan. So there's diffuse plaque here, moderate. There's no neuritic plaque in this case, so the neurons aren't being affected so much by the amyloid. BROC2. So the teaching point is this lower intensity positive amyloid PET is common in Lewy body dementia. Now there's going to be a question on your iPad, a polling question which you need to take a look at, answer that. Okay, another amyloid PET here. This amyloid PET scan is negative, positive, or you're not sure. I hope this is getting really easy. So this is a positive PET scan. Why? Because regional positivity within, and I like to think about, I like to see this in a couple of adjacent slices. You can get in trouble if you look at the inferior part of the frontal lobe and just that alone. You want to look at a few slices to make sure you're not seeing some version of white matter that's confusing you. So make sure you see it in a few slices. This is primary age-related tauopathy, so it's a very low-level part case on pathology. There's no There's no neuritic plaque, but diffuse plaque on the right side on autopsy. So regional positivity indicates a positive PET scan. Another question on your iPad. Keeping those iPads busy. Okay, there are some limitations. I mentioned a couple. One other thing I just want to mention quickly is motion. Motion on a negative PET scan will drag that white matter around and blur it. So it may look like there's not as much contrast. How do you tell motion on a PET scan? Look for the scalp line, see if there's two, see if somehow that line's been blurred as well. That should be always pretty much a thin line. So if you look in these scans here, for example, right here, you always want to see this thin line out here, right? Don't accept it if it's, or raise some caution if there's two or if it's blurred, all right? Also look for asymmetric tracer, one side being brighter than the other. Those are sometimes related to attenuation correction artifacts where the brain on the CT is shifted and it corrects the PET scan incorrectly. Always match your CT scan to your PET scan. Make sure they align. One isn't twisted, shifted. That will change the uptake on your PET scan. You don't want that. You can go back sometimes and reorient the CT, have it redone, and correct that uptake. But you want to make sure you check a few things like that for artifacts. Oops, sorry. Communicating amyloid PET findings. So it's very important as we start out in this imaging that we link up with our clinical teams, that we collaborate and make sure that the right imaging is ordered. I want to discuss templates with the care team, make sure that they have what they need. There's some insurance issues that happen if you say the wrong thing on the result. Right? If it's amyloid positive scan, if you say Alzheimer's disease, that word is picked up by search paradigms, and you may have problems with people getting insurance issues. So, it may turn out to be Alzheimer's disease, but we don't want to do things that, kind of throw a wrench into the care team. Present things at an interdisciplinary conference for a while, see what they're using, see what they want to hear, and follow up on these clinical outcomes on patients that you see in the conferences to learn and help your team learn about what needs to be done and how things will help the total team. Just a few words on tau PET. That's something that, we don't know if we're going to have to use this for classification yet. It certainly is a pathological marker of pathological deposition of tau. It doesn't always mean there's tau pathology. There's other things like TDP43 that can, for some reason, light up in areas, so you have to be also cautious. But it does support the diagnosis, and it is a better predictor of cognitive impairment than amyloid is. So the more people that you look at that have tau positives, more of those people are going to be impaired. And this graph kind of shows that if you have amyloid positives, the blue line on the top, and not tau positive, then the survival probability is much better than even if you have medial temporal tau, as you can see on the bottom here, the medial temporal tau. Also, just a little bit of tau really reduces your outcome. So it is important, and hopefully we'll get that, a better understanding of that, how it folds into all this therapy in the future. I've got a patient case I'm going to show to you from a treatment conference that we had at my institution 4 weeks ago. This patient came in with cognitive testing confirming MCI. The STMS was at 28 this year, had dropped, and that is borderline between MCI and mild dementia. So we need to look at some additional testing, biomarker testing, MRI, and maybe assess their genetic risk factors. So this person had a CSF test that was positive. The ratio at our institution at the moment, and that does change, is 0.035, which is positive. It's above the ratio cutoff. The p-tau 181 was actually in the normal range, but the A-beta 42 was low enough that it kind of made that ratio go positive. The patient was E3, E4. MRI findings. This is the MR as presented, just a couple of slices for you. There was hippocampal atrophy, 3 microbleeds, which is an exclusion for therapy at that number, and Circe will talk more about that. We saw the report saying frontal atrophy in this case. So at conference, it was pointed out, by a lot of people that this is really a CSF dynamics issue, and we've got that as an added pathology, if you will, in this particular case. So a polling question here for you now. This is the amyloid scan on this same patient. It's a florbetapir scan. And is this scan negative, positive, or aren't you sure? You're right, it's positive. Now, why is this a little bit of a challenge? Because of the CSF dynamics, you see some areas that maybe someone could confuse with, areas that are not just filling all the gray matter. Some areas that people point to that should be maybe more full. They aren't because of this person's CSF dynamics issue. So slightly confusing, but not a huge reason to call this negative. There's lots of areas that are filling out nicely right to the gray matter ribbon. So discussion on this particular patient, that the patient has targetable disease with the positive tests, has a moderate side effect risk from some presence of microbleeds, but not exclusionary. We've got this side effect profile with CSF dynamic issues. What do you do about that? Well, you're going to find a lot of patients who have diseases that were not in the trial. Cancers, all kinds of things. They will likely, at some point, have additional side effects that we don't know about. So you have to talk to people about other pathologies that they have that weren't at all described in the therapeutic trials, because we have had outcomes from other diseases that are basically just showing up now and will be part of the literature we come up with in the future. Hippocampal atrophy, probably the area that's mentioned on the MRI that's of significance. This could be TDP-43 as the driver of the cognitive impairment. How do you sort that out? Alzheimer's disease. Well, some tau biomarker, tau PET might help in this case. So that was suggested as an option. And then in the end, the patient was offered treatment with some consultation about the risk profile. So that ends my discussion, and we're going to turn the time over to Cyrus now. Thank you.
Thank you, Dr. Lowe, for such an excellent presentation, and to all of you for joining us this morning. So this slide shows what many of you are already familiar with in terms of the use of MRI for Alzheimer's disease that you may have learned in residency, ruling out other causes. We see these familiar looking coronal T1 weighted images showing the normal hippocampal volume and controls, mild cognitive impairment, and mild Alzheimer's disease. But I doubt very much that the majority of you would feel comfortable calling Alzheimer's pathology in practice just based on these images alone. And what I'm going to show you today is a new array of sequences and options for tracking Alzheimer's diagnostic utility, as well as, of course, the treatment implications. And so one of the new techniques that I want us to briefly go into before going into the therapy-related findings is arterial spin-labeled MRI, which is a technique for tracking cerebral blood flow that uses radiofrequency pulses to label spins in the water of blood going through the carotid and vertebral system. And when you hear about ASL, there are all sorts of varieties of ASL. There's CASL, there's PASL, there's PCASL. And the key thing to understand is for your practice, it's important to investigate the option of looking at 3D PCASL, or pseudo-continuous ASL, which is the most useful technique for tracking CBF that's available on vendors. And the reason it's important is because when you look at vendors, they'll give you options for pricing that includes every type of ASL you could possibly have, which is more costly. But with just PCASL, you can get a really good assessment of cerebral blood flow. And the reason that's important, as we can see in this recent paper from AJNR that was published out of Dr. Gloria Chang's group at Cornell, shows these really nice images where you have axial and sagittal T1 weighted images, axial and sagittal ASL images projected and fused onto the T1 weighted scan, and then FDG PET images that are also fused onto the T1 scan. And what the arrows are pointing to are parietal and precuneus hypoperfusion on the ASL, which also tracks the results on FDG PET. And this is in somebody with a presenilin mutation, so not only getting Alzheimer's disease, but the earlier version of Alzheimer's disease that starts in the 50s. And so this is a very sensitive technique that shows hypoperfusion related to hypometabolism, and this reflects a lot of the other sequences that have been tested against FDG PET. And why is this important? Well, one, this is product sequence. This is not a research sequence. Number two, we can deploy 40 million MRI scans a year in this country, where we can only do a maximum of around 2 million PET scans based on the current infrastructure. And since there's a priority towards amyloid PET, tau PET, being able to save a radioactive dose, but also giving sensitivity comparable to FDG PET with ASL is going to be highly clinically impactful in refining the confidence in the diagnosis and correlating these sequences to the fluid biomarkers as well as the molecular imaging that Dr. Lowe so nicely overviewed. And of course, we know from earlier studies that ASL is very sensitive in detecting what eventually tracks as changes on other types of molecular and advanced neuroimaging. This is data looking at over 7,000 images in over 1,100 individuals in the ADNI, and seeing that ASL perfusion was actually very sensitive in tracking change. And this was with PASL, which is not even the most advanced version that we can see on product sequence now. But I'm also here today to really focus on amyloid-related imaging abnormalities. And the best way to understand these sorts of changes is it's edema and bleeds that can happen in a certain number of cases based on a certain profile of imaging and risk factors in individuals undergoing immunotherapy for anti-amyloid treatment. And it's really conceptually very similar to treatment changes that you might see on brain tumor imaging. When you have chemo, when you have radiation, when you can see tumors that can bleed, can have edema, and these are treatment changes essentially that we can see. And conceptually, I would say that ARIA is very similar. And what you see here, and you can scan with the QR code, are typical sequence protocols. You can scan edema and bleeds with flare and susceptibility sensitive sequences respectively, be it GRE or susceptibility weighted sequences on 1.5 or 3T scanners. And so these are actually tracked on the ASNR website. And when trying to look at specific findings that increase the likelihood of experiencing ARIA, we see that the baseline MRI findings that are very important are large cerebral hemorrhages greater than 10 millimeters in greatest diameter, more than 4 microhemorrhages, which is a very specific number that you'll be tracking in reports, the presence of superficial siderosis or low susceptibility signal in the sulci, and the presence of vasogenic edema. But there are other factors that could also generally increase the risk of intracerebral hemorrhage that are important to track and report, including aneurysms, vascular malformations, infarcts greater than 1.5 centimeters, and extensive diffuse white matter disease, so vesicus 2 or 3, kind of that increased confluence of flare hyperintensities around the ventricles will be important to track as well. You're going to have a question on your iPad that you can take in terms of a pretest. And let's go into an actual case where we show an example of applying some of the advanced sequences that I was talking to you about earlier. This is an example of an individual experiencing cognitive decline over a 1-year time course. This is somebody in their late 50s to early 60s. And what you're seeing here are an example of color-coded segmentations that can be available on any variety of FDA-cleared volumetric algorithms. There's no need to go into the specific vendor names, but there are about close to 24 different FDA-cleared algorithms out there. And so whatever you want to use in your practice, you might get segmentation similar to this. And it's important to note that when you're using these statistical comparisons at different time points, it is important to use those metrics to track what are abnormal brain regions, and we see a whole list of lobar structures having low brain volumes compared to normative data. But more important than that is to track the change in volume over time. And so what I'm showing you here between time 1 and time 2 are these graphs that you might see tracking the brain volumes compared to normative data. And the fact that you see a lot of these black dots in the kind of orange areas show that they're quite on the lower end compared to the normal database. But what I like to do is I like to actually calculate the change in the volume itself on an annualized basis. Not the percentile, but the volume, because in the literature, we actually have data reporting from ADNI and Dr. Jack's group at Mayo and others what the percent changes. And so to give you some perspective, if you're age 30, you start losing 0.2% of your brain volume a year. When you start at 60, you start losing 0.5% of brain volume a year, so that's compound interest in the wrong direction. And then when you start getting Alzheimer's disease, you start losing 2 to 5% of brain volume a year, depending on the specific region. And so we see here that hippocampal volume is dropping at negative 2.23%. We see lobar volumes are also comparable, dropping between 3% ventricular volumes go up. In this case, just under 5%, although typically at a rate of 10% a year in most individuals. And so why is that important? Because progressive atrophy, not just low brain volume at any one time point, is a key finding in Alzheimer's disease and neurodegenerative disease in general. And so longitudinal imaging is going to be very important. So if you're reading a study and you're not sure if these low brain volumes at one time point mean anything, get a follow-up scan in a year and you'll have greater confidence in the progressive atrophy. And of course, perhaps having other fluid biomarkers of Alzheimer's disease pathology as well. But the ASL really helps in this case as well, because what you can see here, again, this is product sequence. This is not a research sequence. You can get this on a variety of scanners out there. This is in a GE scanner in this case, and they give really good cerebral blood flow maps. And what you're seeing here are sagittal ASL images. And what the arrow is pointing to is the precuneus and the superior parietal region. And so these kind of blue colors show progressively lower areas of cerebral blood flow. And you can see over the course of a year, we see progressive loss of perfusion. And so this, in conjunction with progressive atrophy, really helps improve the confidence in understanding the presence of neurodegeneration related to Alzheimer's disease, which is really what atrophy, ASL, and FDG PET should be tracking. But we actually have research software, so this is not a clinical product, but a research software, where you can start to estimate Alzheimer's probability in terms of isolating specific regions that we know are vulnerable to Alzheimer's disease, comparing them to publicly available research data. And in this case, this particular software program used in research generates an Alzheimer's probability comparing the hippocampus, amygdala, and inferior lateral ventricle, or HAVA regions, as it's termed in an acronym, and looking at the Alzheimer's probability compared to, in this case, a combination of publicly available databases such as ADNI or OASIS data, research databases where we actually know the status of these individuals, and we can see that the probability is greater than 90%. So imagine a future where, in addition to your individual reads, quantitative information, you're actually getting AI-assisted information on the diagnosis. And of course, in this particular case, this is an amyloid-positive PET. And again, if you read the radiographics article, this is very much the kind of, tree and summer look where you can't see the delineation between the gray matter and the white matter border, as opposed to the tree and winter look where you can see the white matter delineated from the gray matter on a negative scan. And again, in talking about the new monoclonal therapies for Alzheimer's disease, so, lecanemab, donanemab, Aduhelm, these drugs that you hear about, we can see that ARIA monitoring and detection with MRI is important. And so you might have heard a statistic that there might be upwards of 15 million additional brain MRIs over the next several years for individuals with Alzheimer's disease just for treatment monitoring. Now, where that number comes from is, if there are 5 million individuals with Alzheimer's disease in the country who are eligible for treatment, there are about over 7 million total, and each of them needs 3 scans tracked here at initiation prior to therapy, at the 5th infusion, and at the 7th infusion. Again, you can imagine how you can get up to that 15 million number quickly, and that's if no patient actually gets amyloid-related imaging abnormalities. If they do get amyloid-related imaging abnormalities, they'll need to have scans more frequently until at least the edema resolves and you can see the evolution of the hemorrhages. And so, again, in terms of the protocols, we talked about the FLAIR, T2, DWI as being additional sequences or sequences together. So FLAIR will help you track your edema, susceptibility-weighted imaging. GR will help you track the microbleeds and hemorrhages. And in our practice, we get both. We get susceptibility-weighted imaging and gradient echo, because sometimes you'll see vessels in profile with SWI that can be confusing, and then the GRE can help you delineate that. It's a 10-minute scan overall, and that's important because in monitoring individuals, you may want to pare down your protocol to prioritize the FLAIR and the susceptibility-weighted imaging so you can reduce your scan time and still do these assessments. Although on your baseline, you may have a more complete protocol looking at other sequences as well. And of course, especially in symptomatic individuals where you don't have a scheduled MRI, paring down the protocol to those essential sequences, DWI to look for stroke, FLAIR, T2 star, and SDBY will be very important. And again, this comes out to about a 25-minute sequence, especially if you have general brain sequences at the same time. Again, when you look at the actual symptoms of ARIA, they can be very overlapping with other conditions. You can have headache, mental status changes, confusions, nausea, emesis, and of course, symptoms can be mild, moderate, or severe, where they can be incapacitating on the severe side. And the differential can be very broad, but it can include things like stroke, infection, or press. And so it's really important when you're reading these scans and you think, I think that might look like press, or this might look like, it's important to try to get the history, especially if you know the individual has a history of cognitive decline, dementia. It's important to find out, are they on A-beta immunotherapy? At our institution, we have over 200 patients right now on A-beta immunotherapy. You'll see this increasingly be the case at other areas around the country. And again, in looking at examples of what ARIA-E or the edema versus ARIA-H look like, each one of these findings have two flavors. So the edema is vasogenic edema, which we see here noted on this flare, circled in red. And of course, effusions can also happen as well as part of ARIA-E, which we can see kind of in these areas of flare, high signal, and the sulci. And then, of course, ARIA-H, you can have microhemorrhages or superficial siderosis. So again, parenchymal versus kind of sulcal-based findings that we can see here. And of course, in looking at the ARIA classification criteria, it's important to kind of have this sort of printout up in your reading room, maybe on the wall or easily accessible for reference. And a couple of things I'll point out here. So for ARIA-E, going from mild, moderate to severe, it's really mild is less than 5 centimeters, moderate is less than 10, and then severe is greater than 10. And of course, you can have multiple sites involved. ARIA-H, less than or equal to 4 new incident microhemorrhages is mild, 5 to 9 is moderate, and greater than 10 is severe. For superficial siderosis, you can have mild ARIA-H for superficial siderosis, which is as little as 1 focal area. And that's important to note and scrutinize the images very carefully. And so again, in terms of grading, we see examples here. We can, look at the different measurements. And again, in terms of mild ARIA-E, you can have sulcal flare, high signal, with ARIA-E, with this moderate, it can be parenchymal. And then of course, same thing with the hemorrhages, 5 to 10 is moderate, greater than 10 is. So again, the other thing to note in practice is these hemorrhages can be tiny. They can be very small. And the siderosis can be as small as an eyelash. So it's really important to scrutinize the images very carefully in order to look for these. And again, if you can use reformats for volumetric acquisitions, that'll be helpful as well. This is another polling question. Again, in terms of the time course, the point of this slide is to note that in terms of the ARIA-E, what typically happens when you see that is the doses can be stopped, especially if there are symptoms involved. And ARIA-E can typically resolve, but the hemorrhages often persist, and so that's important to note as well. There can be mimics of ARIA, and so for instance, what we're seeing here are examples of that kind of typical vendor-based hyperintensity you can see around the occipital aspect of the ventricles. You can see that supplemental oxygen can kind of lead to flare non-suppression. Susceptibility-weighted imaging findings can be mimicked by hearing aids and such. And then of course, you can have poor CSF suppression as well. So in terms of results being communicated, you have to establish that practice within your own institution. It's important to have standard templates. We have certain guides for template reporting on the ASNR website that we're sharing. And then of course, even if you have a mild radiographic ARIA, it's important to call and let individuals know, because many times these are going to be screening or follow-ups, and there might not be a symptom correlate that they know about. But then if you report it, they can track to see if there are any actual symptoms. Again, these are the templates, and these are available at the QR code, which will be available in the slides. There are newer AI-based tools that are being provided in terms of trying to track ARIA, and you'll probably see a couple of vendors talking about that today. And I think as you try to supplement this sort of technology in your practice, as much as AI can be potentially helpful in Alzheimer's diagnostic support, in terms of identifying ARIA, we can see at least 2 companies here that are providing this with NeuroQuant and Icometrics. And there are billing codes that can actually pay for these as well. And so these are examples of readouts measuring and tracking these findings over time. And so let's go to some patient cases. Again, this is an example of an individual with kind of new bilateral right occipital and frontal parietal flare, white matter hyperintensities. These are edema, these are effusions. There's no microbleeds or siderosis. And so what do we have here in terms of the diagnosis? And this is ARIA, but the important thing to note is the history. You can't really say this definitively unless you have the history. So again, tracking that from the get-go is going to be super important. In terms of assuming that this is ARIA and that we know the history, what's the severity? So again, we have measurements of 4.8 and 6.8 centimeters. So again, is this moderate RAE, moderate RAH, moderate RAE and severe RAH, or severe RAE, or are we not sure? So this is severe RAE, as evidenced by the fact that we have multiple areas of hyperintensities on the vasogenic edema, and of course, again, between 5 and 10 centimeters in this case. This is an individual right here that has a new finding of flare hyperintensity, microhemorrhages, restricted diffusion. And again, we don't know the history of treatment in this case, but what would you say this finding represents? Kind of just thinking about your typical neuroradiology differential. So again, is it ARIA, infarct, brain met infection, or unknown? That's actually infarct. So again, the fact that you have restricted diffusion is really important, and of course, you won't typically see that as much with ARIA. And why is this important? It's important because if somebody who's coming in with a stroke has ARIA, especially ARIA hemorrhages, and they get thrombolytics, in at least one case of the trial, this has led to death. And so, as neuroradiologists, you are the main guardrail on patient safety in terms of these sorts of findings, protocols, reporting, and communication of results. And so familiarizing yourself with ARIA findings, and again, we have a paper out in the AJNR from 2022, and we have an additional paper coming out hopefully soon, and looking at these sorts of educational resources will be important in refining and applying these sorts of insights into your practice. And so thank you so much for your time, and appreciate it very much.
Do we have time for questions? I don't know what the time is. Maybe so. Anybody have any questions? I don't know if we have mics. We have a mic there and a mic over here. So if you have any questions, approach the mics. There comes one over here.
Excellent session. One of my questions is regarding volume loss under the treatment of amyloid antibodies. How do you differentiate the normal progression of volume loss compared to that of the treatment itself?
So I could take that question. I think that, looking at the related edema changes and fluid shifts will be very important. And this is actually already known in the MS world. So in multiple sclerosis, there's the phenomenon of pseudoatrophy that could happen when you have edema. It's also important to understand that some of the volume loss may be very well happening because as we're clearing amyloid from the brain, clearing toxin out, we're clearing out volume essentially from the brain. And so especially if you're seeing volume loss, but it's not as pronounced in, for instance, the hippocampus or cognitively relevant structures, I personally, in my own practice, would favor that to be more of a pseudoatrophy effect, especially if the related clinical picture of cognition is improving as opposed to declining. And I'd love to get the clinical perspective from Dr. Lowe on that.
Yeah, I missed that. I was reading the chat here. On the right.
Yeah, great talk. Thank you so much. Quick question. Does ARIA-H ever occur alone without ARIA-E? Or is there always ARIA-E when we see ARIA-H?
I've definitely seen ARIA-H in isolation of ARIA-E. And I've seen ARIA-E in isolation of ARIA-H, and I've seen both.
Thank you.
Question from the chat here. How do amyloid PET and tau PET compare to FDG PET with respect to sensitivity and specificity for making an early differential diagnosis of Alzheimer's disease? So, we've got a lot more experience with FDG PET, and one thing that FDG PET shows is clinically affected areas of the brain, right? So, in a sense, that's somewhat non-specific because it can be related to different pathologies that may involve those same regions. So, if you have to say, which of those is the best, I mean, it really is tough because you need to have pathologic and very specific identifiers, which you get with amyloid and tau PET. So we tend to use FDG PET as sort of the first blush of the first approach to what might be abnormal. Payments easier for that test. And then after that, if we need to know specific pathologies, we would move on to the other two. There's an ARIA question here. Cyrus, you want to deal with that?
Right, so the question is, what is the difference in risk for serious ARIA between homozygous and heterozygous for APOE4 carriers? And that's a very good point. APOE4, homozygous carriers are by far at a higher risk for ARIA than heterozygotes. And so that is important to track in terms of a risk factor.
Okay. How do you classify a PET scan with borderline contrast between gray and white matter? So, and that's where the rub is, right? Is how much contrast is contrast. And I think one thing you can do is look at the normal area of the brain, and that could be in terms of reading the cerebellar gray matter, and say, is that intensity similar to what you're focusing on? And you want to make sure that if you can make that comparison, the intent, and visually, I mean, you can do this quantitatively, if that visual comparison is about the same, you can be comfortable that that activity you're focusing on in the gray matter is probably just a normal amount of activity. It's always going to be a little bit blurred, and so that's tough. I think the other thing to do is to, page through the images, see if there's similar findings on different axial views. Question on the left here.
So we have this plaque and tangle conference, which is like a tumor board for these cases. And something that often arises is this concept of a Fazekas 2.5. Like this is, I don't think the Fazekas scale was ever meant to be used in this way. Some folks feel comfortable treating with severe small vessel disease. How we define that is sort of unclear. I think it would be better to use white matter hyperintensity volume, but how do you all deal with this issue?
I can take that one. I understand your point, and I've also thought of the Fazekas 2.5 issue. The issue with white matter hyperintensity volume from a segmentation standpoint is these algorithms often miss the posterior fossa. So trying to track the posterior fossa, especially if there are brainstem white matter hyperintensities, which can happen in severe hypertension, I think is a blind spot there. I think newer algorithms pairing it with T2, which tracks the posterior fossa better, will be the way to go. And I think, yes, having volumes will be an important way to track this in the future, but ultimately I think your opinion as the neuroradiologist will also ultimately stand, and sometimes there'll still be some of that ambiguity between 2 and 3.
Can these scans be accurately interpreted by individuals who only occasionally review them, or should each practice have a designated reader specializing in these scans? Well, we face that with pretty much everything, right? And I think optimally, you have somebody who specializes and does it daily, right? Sometimes that's practically impossible, but I think the answer to that question is it'd be great to have somebody who specializes. I think there's another ARIA question right there.
So how to deal with quantitative thresholds for ARIA-H when having different MRI sequences for baseline versus follow-up, especially SWI with higher sensitivity versus T2. I think that if you have to choose between the sensitivity of SWI and T2 star, you report the SWI findings, and whatever's giving you the most information, you track that. If you're not confident you can get a good assessment, then if somebody's coming into your practice with a lower resolution T2 star scan, you should rescan them on your standard protocol. And it's better to go through that step and be confident in what you're assessing than having that uncertainty, because it does have clinical implications.
All right, thanks everybody. It's been a pleasure to be with you this morning. I hope you have an enjoyable rest of your day. Thank you.
Thank you.